So welcome to AC 702 Wednesday seminars. Tonight we'll have Dr. Winston DeMello talk about environmental injuries, but make sure that you catch the podcast, the Basic Scotland podcast this week. Dr. DeMello is hosted on the Basic Scotland podcast, talking about burns, and definitely something you want to catch. But for tonight, we'll talk about environmental injuries. Winston, over to you, sir.
Thanks, Ibrick. Good evening, everyone. Today's topic is environmental disorders, concentrating on hypothermia and hypothermia. And depending on how time goes, I'll also cover drowning. And if we don't have the time, you'll at least have the slides to look at later. I'm going to start with two case studies, and this is going to be hopefully interactive. The first case is a 22-year-old female. She's a keen athlete. She presents to your clinic with a 4-hour history of tremor and muscle spasms. She has a history of migraine. She has no family history of any medical problems. Her last period was 2 weeks ago. She's on a triptan for a migraine, oral contraceptive pill, tryptamine supplements, and St. John's wort. No known allergies. She's alert but very agitated. Respiratory rate 16, saturation on room air 98%, sinus tachycardia, BP 150/100, sweaty, fine tremor, dilated pupils, oral temperature 39 degrees, and she is hyperreflexic on neurological testing. Any comments? Oh, Thomas, a poor internet connection. He's mentioned heat stroke, athlete running in a high environment. Let's put it this way. It's in the morning and she hasn't been running for the last 24 hours.
Can we be suspecting stroke?
Why do you say a stroke?
Well, the BP seems a bit high.
Yep.
Coupled with the migraine
Mm-hmm.
and dilated pupils
Mm-hmm.
with a bit of tremor, which is more like involuntary movement. Some may have that as well.
Okay, so you're
Out of differentials.
yeah. So you're putting your money on this being a CNS event. If I said to you that the neurology is completely normal, other than the hyperreflexia and the dilated pupils, there was no other localizing neurology.
Any possibility of malignant hyperthermia?
You're on the right track, but it's not, strictly speaking, malignant hypothermia, because she's got no provoking events leading to it. But you're on the right track. The clue is in the on the slide. What information on those slides can give you a hyperpyrexia?
Is the temperature that you see and the pulse itself?
No, I mean what in the history would suggest a high temperature being the cause of it?
There's the history of sweating. Then you also got muscle spasm.
Yep.
Mm-hmm. The history of tremor.
Yep.
Dilated pupils. Can actually show you that. That agitation is something to worry about.
Okay. So do you have any idea? You said malignant hyperpyrexia, but I said you're on the right track. There is a hypothermic problem, but it's not due to MH, malignant hyperpyrexia. It's some other cause. So what in the history that's on the slide would suggest another cause of a high temperature? Just from the slide.
I need to look into those and side effects of the drugs that she may be taking.
Correct. Okay. So do you have any idea as to what those drugs and the relationship to high temperature? Anyone? Okay, I'll explain to you.
OC pill?
Sorry?
Could it be the OC pill?
No, it's everything but the OC pill.
Okay.
So it's the other drugs. Does anybody want to take a guess at that? Okay, I won't give you the answer because we will find it as we go along. The second case is a 24-year-old male. He was at a Christmas party last night. He was drinking a lot of alcohol. On his way home, he became very manic and jumped into a lake. He was pulled out by his friends. Submersion time about 5 minutes. He had a heart rate of 130 regular. He was cold to touch. He was mumbling, rumbling, aggressive episodically. And as you're examining him, he relieved himself of urine. How are you going to manage him? Why is this submersion going to be a big problem for this man? What does alcohol do to your body?
So he's vasodilated and then immersed in cold water.
Excellent. Okay. What about this? His behavior, the mumbling, rumbling, Tom. What do you think is going on there?
I think the obvious go-to answer is that they're the umbles from hypothermia, but then you have to wonder if you could be missing something. There could be another reason why he jumped into the lake and was acting weird, but it could just be hypothermia.
Yep, good. And what about the relief of urine?
I suspect there's a clever answer why you've put that there, but my mind's gone blank.
Okay. Does anybody want to have a stab at the first case? Looking at tryptophan supplement, St. John's wort, which is a herbal remedy for depression.
Well, I mean, they all affect the metabolic rates and therefore affect temperature.
Yep, you're right, John. And what's the receptor involved?
I'm sorry, say again.
You're quite right. You're right with the answer, but I was just going to ask you what receptor is involved in common with tryptophan supplements and St. John's wort? Which transmitter?
Isn't it serotonin?
Excellent. Well done. You get the first prize. Well done, John. So the first case is a case of serotonin syndrome. Tryptophan supplement, which is a 5-HT chemical. St. John's wort promotes serotonin. So on starting more than one serotonin-based drug, you're very likely to have a serotonin syndrome. And the secret is it's a short history, 4 hours. The whole body goes into sympathetic overdrive. You've got a tremor and you've got muscle spasms. They tend to be alert, but they're very agitated. They have a higher temperature for the reasons we'll see in a second, and they're hyperreflexic. So the clue is in the history, and this 4-hour short history suggests something acutely going on. So let's look at temperature control. All of us, all mammals, are homeostatic, and we try and control our temperature independent of the external. Man are endotherms as opposed to ectotherms. The problem occurs when you are burnt, when you become poikilothermic, or if you're newborn, neonatal, immature, newborn, you require a higher ambient temperature to prevent heat loss. Variations on temperature can be on a circadian rhythm and also a slight drop prior to menses. Most of your heat is by food oxidation and the use of stored energy from things like brown fat. You need heat, which is essential for cell survival, and that is a continuous process. But if you're working out or having some physical activity, that's intermittent and that's facultative, and that is non-shivering. However, if the environmental heat is beyond 35 degrees, you tend to get heat from the environment, and that's a big problem. And you lose heat by 4 processes: vaporization, radiation, convection, and conduction, of which conduction is really not relevant unless you happen to be touching a hot surface, like an epileptic old man who's had a fit and then is a false slump against a hot radiator. And it's affected by high ambient temperature or humidity. So if this process is disrupted, you get either high temperature or low temperature, but both will cause ischemia and multi-organ failure and death. There is a big difference between a viral illness calling a fever as opposed to hypothermia, which can be exogenous. And the whole process in a fever is the COX-2 enzyme that converts arachidonic acid to prostaglandin E2, and then resetting the thermogenic set point. And in hypothermia, you sweat, and in hypothermia, you have a shivering reflex and activation of the erector pili of the hair on your body. The mechanisms, here you can see the TRP channel, transient receptor potential channel. There are about 9 types: cold as in menthol, hot as in chilies, and it's the TRP receptors that actually provide the information. So you've got information coming from the ambient temperature and humidity, and then you've got temperature coming from muscle activity. That is fed into the spinal cord, into the hypothalamus, and then projected onto the somatosensory cortex. The preoptic area is where the cold response occurs, and it's the posterior hypothalamus where the hot response occurs. And the body then goes into autonomic response, getting sympathetic nervous activation by getting your vasodilatation and also cholinergic pathway, therefore increasing sweating. And there are lots of reasons why you can get cold, and also lots of reasons why you can get a high temperature. 50% of patients that you are likely to meet are going to be due to infection. You remember the case study number 2, the young man who fell into the lake. The reason why he relieved himself of urine is that you get a cold diuresis to a reduction in ADH. So it's not a release of urine post-ictal, but it's actually a cold diuresis due to the suppression of ADH production. And therefore, these patients, when they're warmed up, will collapse, because when you vasodilate, the relative hypovolemia becomes obvious. Now, in thermoregulation, you've got your core body temperature, and then you've got your mantle. And if the core is overheating, you need to transfer the heat from the core into the mantle, and then obviously to the surface. And as I've shown you, temperature sensing occurs within the skin, within the deep core tissue, usually in the abdominal viscera and large blood vessels, and centrally within the brain. If your threshold is increased, there are 3 things that happen. Behavioral changes. If you feel cold, you go and put a jumper on. If you feel hot, you take some clothing off. And so if you're critically ill, you lose that behavior contribution, and you rely on the autonomic nervous system and the endocrine, which is slightly slower in effect due to the increase in cortisol and adrenaline, or epinephrine for our American colleagues. So your core temperature is controlled within a tight range with a 0.5 to 1 degree circadian rhythm, lowest at 6 in the morning, peaks in the evening. And this ability diminishes as you get older. So an elderly person is more likely to succumb to a heat problem than compared to a fit adult. Patients in ITU become cold almost invariably because anesthetic agents, opioids, all lose heat, and sedatives, adrenergic drugs, cholinergic drugs, neuromuscular blockade, ambient temperature, exposure to the environment, IV fluids, extracorporeal blood flow through ECMO or dialysis, impaired brain activity or cardiovascular activity, and lack of substrate like glucose, it's going to be a problem. So you're almost guaranteed to run into problems when you are in ITU. The difference between hypothermia and fever is hypothermia is exogenous, while fever is mainly a problem due to cytokine release. Although nowadays we think even the hypothermia may have some involvement in cytokines, but in this case it's protective as opposed to being destructive, when we talk about a fever. So a fever is defined as a core temperature above 38.3. And if the core temperature is above 41 degrees, it's hypothermia and not fever. So anyone with a temperature of core temperature above 41 degrees cannot be hot due to a fever, but it's hypothermia from some other cause, and you need to look for it. And the question is fever beneficial or not? Nobody knows the answer to that. But a temperature above 43 degrees core temperature is life-threatening. I can't stress this enough to you. So anything to try getting the temperature down is okay. But if it's a short-term core temperature above 40 in an otherwise fit person, it can be well tolerated. Now, all the organs are involved, and you can see it's a cardiovascular system. You've got the hyperdynamic situation. In the brain, you get ischemia and edema, which will reduce electrical activity, and that can be a nidus for fits and seizures. The gut increases gut permeability, so you've got translocation of bacteria across the bowel, and that's the start of multi-organ system failure due to sepsis. The respiratory system also is under sympathetic overdrive, but you can also develop ARDS and non-cardiogenic pulmonary edema. The big problem with the kidney is your renal failure, acute renal failure, both in hypothermia and hypothermia for the different reasons. In the hypothermia, it's the relative hypovolemia that is a big pre-renal cause. And then what really kills the people or causes multi-organ is the DIC or microthrombi production. And at the metabolism, you get a drop in blood glucose, and obviously as a result of the metabolic acidosis and the compensatory respiratory alkalosis, you know you're going to have problems to sort out. As I said to you, of all the ways of losing heat, radiation, convection, and evaporation is the best. Conduction is a very poor method of cooling. But you need to look at environmental parameters, especially the ambient temperature and relative humidity, and also task-dependent parameters. What are you doing? What are you wearing? What's your pre-hydration status? What is your work energy levels? How many breaks do you take from the exercise? And as you can see, your internal heat production minus your loss in the environment will actually dictate what your core temperature is. Now, if you're looking at the reasons why people get heat exhaustion or in extremis heat stroke, there's so many factors. The biggest one in terms of the environment is the high wet bulb globe temperature. So if you're working in a hot area, this is going to dictate whether you're going to allow your team to work in those conditions. Because as you can see in the chart, depending on the wet bulb globe temperature, will also give you a stratified risk problem. And the maximum temperature in which humans can survive in is about 35 degrees and a humidity between 30 to 60%. But there are also individual factors and work constraints. The one that I always worry about is people who are not acclimatized to the area, like Dr. Sanger's case study from Kilimanjaro, altitude sickness in a tourist without acclimatizing. Military personnel tend to be less of a problem because they're usually quite fit. Then your lifestyle factors. You remember the boy who jumped into the lake? He had a lot of alcohol in. He could have been taking illicit drugs. And the young lady that had a serotonin supplement helped herself to St. John's wort, which is a herbal remedy, but increases tryptophan production and serotonin, and therefore you tend to get serotonin syndrome if you take 2 or more serotonin-based drugs. And then obviously health factors, what else is going on? Somebody mentioned malignant hypothermia, but there are other sort of health factors that need to be taken into account. And one of the easiest ways of working out is looking at the color of the urine from the patient. The darker the urine, the suggestion is that they are likely to be fluid depleted. And as you can see, depending on which organ is affected, you get a systemic and regional higher extraction of oxygen, which then leads to fatigue and volitional exhaustion. So once you reach that state, that's where the problem is. And like everything in critical care, the coagulation system is activated, and that is provides the basis for DIC and microemboli production. Now, some of you may note that a big bugbear for me is how to cool a hypothermic patient. Every 13 years during the pilgrimage to Mecca and Medina, it coincides with the hottest time of the year, and thousands, literally thousands, get heat stroke. And in the 80s, Professor Seraj from Riyadh University basically got some stretchers with a head down position, put them into a perspex glass, and blew steam into the environment, and then hot air. And that was the quickest way of cooling somebody, because the latent heat of evaporation is the coolest way of reducing heat from the body. But in clinical terms, cold water immersion is the best. Then obviously your mixed method, which we've talked about. And you can see even after you've started cooling, fanning and water spraying is important. So in the sort of poor resource environments, you can use your ice packs in the neck, in the groin, but please be careful that you don't give a cold burn to these patients. You can give cold IV fluids, blow cool air, but make sure that the gauze you put is tepid, because otherwise if you start shivering, it's A, unpleasant, B, it increases heat production. The more modern method is cooling helmets, endovascular cooling by taking an ECMO circuit, cooling vests, cooling pads, and cooling blankets. You're unlikely to get these in your limited, resource limited, but I think you need to know this for your educational purposes. And cooling can decrease the temperature by about 0.15 per minute, and you're trying to get a target of 38.8. Because after you've stopped cooling, you get to get an after drop as the cooler temperature from the periphery come back into the center. So that's the reason why you don't go cool to normothermia. And what you'll be surprised at is that there's a huge differential for heat hypothermia. Heat stroke is known to everyone. Drugs are very, very common cause. Malignant hyperpyrexia occurs usually in anesthesia due to exposure to inhalation agents or to succinylcholine. It runs in families, and it's due to a ryanodine receptor abnormality, although 30% of patients with a family history of MH tend to have normal receptors. Neuroleptic malignant syndrome is a problem when you put patients on antipsychotic drugs. A few of them will develop neuroleptic syndrome. Serotonin we talked about. Be careful with this because it's actually quite common, and if you don't take a proper drug history from your patients, like St. John's wort or tryptophan and nutritional supplements, you're going to miss out on the diagnosis. Any anticholinergic drugs, any sympathomimetic drugs, any aspirin overdose can also cause it, and monoamine oxidase inhibitors are very a powerful antipsychotic drug. But basically, if you are on this medication and you take tyramine, cheese, or red wine, you get this hypothermia, and you can even stroke on it. And if you're withdrawing from high alcohol levels or benzodiazepines or baclofen, you can also develop hypothermia. The endocrine disorders people tend to forget. Thyrotoxicosis is one, and pheochromocytoma is a malignancy of the adrenal gland, and basically you've got an overproduction of adrenaline or epinephrine, and unless you beta block and alpha block these patients and get them to a tertiary center, they'll die. Some of you mentioned the CNS disease, like the hypothalamic stroke, because remember the hypothalamus is critical in temperature regulation, and if you've got the optic area involved or the posterior hypothalamus involved, you can get hypothermia. If you're fitting, your muscles are generating heat, and unless you stop the fits, that endogenous heat production is just going to carry on. Granulomatous disease is small print stuff. These patients will be ill, like Wegener's granuloma, so the diagnosis will be obvious. Infectious diseases are very common, and if you're in Africa, you're going to have to think of malaria, and obviously if you're in an unprotected area, tetanus is. Cerebral abscess are missed, mainly because people tend to forget that you can get a cerebral abscess from sinusitis, from nasal infections, orbital infections, etc. And if you've got an infection around the target area, around the eyes and nose, the drainage is to the cavernous sinus venous system, and that's where it will inoculate a brain matter and then result in a brain abscess. And then obviously psychiatric disease like lethal catatonia is rare, but it's just for completion. And if a patient's on ICU, 50% of hypothermia will be due to infection. But you can also get it from inflammation. Don't forget trauma, burns, surgery, pancreatitis, all hypercatabolic phenomenon are a cause of hypothermia. My mother, she was 60 when was admitted to a teaching hospital in London with acalculous cholecystitis. It was a diagnosis that was missed, and she was dead within 24 hours. So these are the sources that you're going to look for infection in a critically ill patient. Your endocrine disorders, we mentioned thyrotoxicosis and FeO, but also adrenal corticoid insufficiency, Addison's disease, where the patient just feels tired, it just doesn't seem to cope, very sort of vague symptoms. And remember, thyroid disease, especially mixed edema, can be very subtle because it isn't instantaneous. It is a much slower process. Seizures we've mentioned, infarction can cause a rise in temperature, and hemorrhage, especially in a subarachnoid hemorrhage or bleeding within the gut, or if you've got a massive hematoma that's being reabsorbed, the liver is trying to metabolize the broken down products, and that will raise the metabolic rate, and they get a temperature. If you transfuse somebody with blood products, you can get a reaction. Cancers in themselves can give you malignancy, and if you undergo, say, a prostate operation for a cancer and you destroy a lot of cancer cells, you can get tumor lysis, and that can cause a pyrexia. You can also get hyperuric acid and get gout as a result of that massive breakdown, and adverse reactions to drugs or either from an overdose or withdrawal, as we mentioned in the case of benzodiazepines, alcohol, and baclofen. There are no specific biomarkers. Okay, so you're just basically looking for the markers of organ dysfunction. In your liver functions, there'll be a mild to moderate dysfunction. In your full blood picture, you'll get a leukocytosis, a high white cell count, but a normal hematocrit, unless you have a coagulopathy, especially one as in DIC, where you've got the consumption of platelets. ECG is usually non-specific. So your management, the recommended is a rectal thermometer inserted at least 4 inches. You do not want the thermometer embedded into a stool, because that just makes it less sensitive to changes. And as I've said, a temperature above 43 degrees or 43.5, it depends where you're reading this, is fatal. So you can cool them by physical methods, cool towels, ice packs, cooling blankets, IV fluids. But my favorite is a fine mist of tepid water followed by a blast of hot air. We had 3 cases of heat stroke in Saudi Arabia during Gulf War I. Temperatures of all 3 were in the 40s, 41 degrees. And we just put them head down position, sprayed them with a mist of tepid water. And we asked one of the Royal Air Force engineers to start an Air Force a plane engine. So we blasted hot air over our patients, and all 3 were cooled within 20 minutes. So this, if you have this ready, a way of cooling a patient, remember, have a mist of tepid water and hot air blowing over the patient, not cold air. Because if you put cold air, they'll start shivering. If you put hot air, you bring more heat from the core into the mantle. Paracetamol will only work for a fever of infection. So a fever's infection, it will not work for hypothermia. And for God's sake, be careful about the use of non-steroidals, because as you know, non-steroidals come with problems of their own, and you can make an ill patient worse. So when you're talking about management, you're talking about classical heat stroke, which is what you were thinking of when we were looking at this girl with a hyperpyrexia, and basically measure the temperature, cool them down, take them to cooler space, begin external cooling, keep the ABCs, and get them transferred. But if it's exertional heat stroke, which is completely different, cold water immersion is the quickest and is recommended as first-line intervention. But if that's not available, then cooling techniques like I described could be used. And also remember, don't cool them to normal temperature, but just to 38.9 because of the afterdrop. The outcome really depends on what happens to the brain. The more damage, the worse the outcome, and the areas involved tend to be the cerebella, the hippocampus, midbrain, and thalamus. And these deficits that they get will be cognitive and functional, and these patients will also reduce their life expectancy. So an exposure or an event of heat stroke or hypothermia or hyperpyrexia not only makes you ill for that period, but it actually makes your life expectancy in the future less. Your cardiovascular function, your mortality is higher if you're old and if you've got cardiac disease or a stroke. So in other words, if you have got a CNS and cardiovascular disease and you're then subjected to a high heat thermal injury, then you're more likely to die. And if you've had one episode, provided you avoid the provocating factors, you're more likely to get it second time round. And remember, malignant hyperpyrexia was only discovered in the 60s in Australia, when a whole family, every time they had an anesthetic, dropped dead. And it's only Denborough, the doctor involved, actually looked at it and realized it was a genetic disorder involving the ryanodine receptor. So that's your heat. So the message for heat is cool them as quickly as possible and pay attention to multi-organ support. Hypothermia is the opposite, and now you've got your vasoconstriction, your muscles shivering to try and generate heat, your behavioral response, as we said, putting on more clothes or turning the heating on, and non-shivering thermogenesis, which is basically brown fat, which tends to produce non-shivering thermogenesis, as opposed to shivering, which is an increase in muscle activity. And in your management, you need to have your clothing that is dry, some spaces in between the insulating levels, robust windproof and waterproof outer layer, and a heat pack from whatever source you can get, but make sure that the patient's not on the ground and the patient's insulated. So hypothermia is a core temperature less than 35 degrees. And there are 3 kinds of problems: hypothermia, frostbite, and trench foot. And the risk factors are outdoor activities, those who are drunk, homeless, mentally and physically ill, the age extremes, and the poor. So in big cities, you're more likely to come across these problems. And the 2 types: primary, where it's unintentional exposure to cold temperature, or secondary, either due to a disease process or a treatment called therapeutic hypothermia, where you deliberately drop a temperature as in post-cardiac arrest. So what's the issue with hypothermia? It can occur in so many other disease states: diabetes, hypothyroidism, hypoadrenalism, that's Addison's disease, hypopituitary, that can occur in a lady who's just delivered a baby and got infarction of the pituitary gland. So the history of what happened before might be important. The age extremes find it difficult to cope with temperature. Trauma will cool the patients, and if you are traumatized, remember, if you're cold, your coagulation status is not good, and you can bleed to death. So there's no point in pouring blood products into them if they're cold. So the importance of warming the patients are important. Abuse of alcohol, as Tom said, vasodilates you, and the effects of other drugs, especially things like cocaine, will be a sympathomimetic drug. Those who are poor and with poor nutritional status, especially if you've got very low glycogen storage, you're not going to have the substrate if you've not been eating much, and therefore the body doesn't have the substrate to oxidize food. Severe burns, just like in a premature neonatal, the endotherm, which is the basis for man and all mammals, now is lost, and you become poikilothermic, which means fish-like, and therefore you take over the temperature of the ambient environment, and that is why operating theaters, neonatal units, and burns units run at temperatures of 40 degrees, which is hard work. Hypoglycemia, especially if it's persistent, will cause hypothermia, and then all your sort of cranial neurological disorders like traumatic brain injury, spinal cord injury, hemorrhage, Parkinson's, the alcohol encephalopathy, MS, can all cause it. And really, besides active and passive rewarming, the most important thing is treat the cause. And if you miss something like hypothyroidism, is treated with triiodothyronine, because that is rapidly acting, these patients will be condemned to a very poor quality of life and even death. So depending on what kind of hypothermia you've got, whether it's mild, moderate, or severe, you can see that below 28 degrees, you're basically dead. But remember, you're not dead till you're warm and dead. And in the more mild versions, you've got the sympathetic kick in. And as Tom mentioned, in the mumbles, grumbles, stumbles, and fumbles, neurological behavior. So somebody behaving inappropriately, you think they are a psychiatric, for God's sake, think of an organic cause such as hypothermia. And because of the reduction in ADH production, they'll get a cold diuresis. So the young man who fell into the lake wet himself, and that's not because it was a post-ictal event. That is just the polyuria you get from a cold diuresis due to hypothermia. Frostbite, the tissues are pale, firm, with a pure capillary field test and sensation, but severe cases appear purple because of sludging. And there are different cases of frostbite, and essentially try and warm them carefully, and we'll see how we do it in a second. Trench foot was first described during the First World War. That's why it's called trench foot. The skin will appear red and swollen, blisters with bullae, bleeding into the skin and deeper tissues. And the demarcation of the injury, just like in burns, especially burns from alkali, can be very difficult to ascertain just when you see them for the first time immediately after they've been rescued. So the important thing is to get the temperature measurement by using a low reading temperature probe, either in the lower third of the esophagus or rectum. If they've got a good urinary output, some of the urinary catheters have a thermistor involved, so that can be a non-invasive like. The rectal probe, 4 to 5 inches, but not in feces. Remember, rectal temperature lags behind true core temperature during warming. Laboratory test, you'll get a hemoconcentration, a drop in potassium, a drop in glucose, and the risk of coagulopathy, because remember, coagulation factors are very temperature sensitive. Chest X-ray may show pulmonary edema because of the changes in the respiratory system in the lungs, where you get a right-sided strain. And the ECG classical has the J. Osborne waves, but then you can get lots of other variations on the theme other than just the classical J. Osborne waves. The different sites for temperature measurement: esophageal, bladder, and PA catheter, pulmonary artery catheter, are the best. The tympanic may be the best for our environment, so we're talking about usually using a digital method. Remember, if you're traveling by air, for God's sake, don't carry mercury thermometers, because if these thermometers break and mercury is dropped on the aircraft, you can destroy millions and billions of pounds of aircraft. So that is a no-go on aeromeds. So digital year is probably the best one for our location. So remember, nobody's dead until they are warm and dead. This was Ashcroft's quote from 2000. You have to minimize jerky movement, because if you move these patients in a jerky manner, you get the cold peripheral blood going in centrally, and don't forget the heart is a central organ, and then you might initiate a VF arrest. If they are unresponsive, intubate them to protect the airway. Use warm humidified oxygen. And remember, humidified oxygen is essential. In fact, I think Ebrick and myself in LinkedIn produced an article on humidification of medical gases. I suggest you have a look at it. Remove the cold, wet clothing, dry the patient, cover with dry, start warming and rewarming measures, and then establish what else. How did they get cold? Was it a trauma, or is it due to a disease process, or a combination of factors? So your treatment, if it's mild, is passive external methods like blankets. And what is important is oral hydration if they're able to drink, with sugary drinks, because remember, if food is metabolized, you get the specific dynamic action of food, and that increases the heat production. You've got passive externals like the electric or forced warm air blankets, and active external, warm IV fluids and warm humidified oxygen. But if you've got warm IV fluids, make sure that from the distance from the IV bag to the body is short, because otherwise the fluid will cool by the time it gets to the body. And then you've got your very active internal ones, which basically are very invasive and wouldn't be of much practical use, unless, of course, you have the ability to pass a nasogastric tube or bladder irrigation with some hot fluid. Get them warm and then transfer them to a high level of care. If they're cold, you're going to have problems with your cardiac arrest protocols, because if they've been buried for more than 60 minutes, like under avalanche, then you're not going to, you might consider withholding CPR. In cardiac arrest from alternative causes, if it's witnessed, it's less than 60 minutes, you would consider CPR. But remember, the protocols for CPR vary from country to country. North American and European protocols are very different. Arrhythmias, do not use antiarrhythmics. Pacing and atropine are ineffective for bradycardias for the cold patients. VF, use antiarrhythmics and repeated defibrillation only after the body's been warmed to above 30 degrees. Do not use lidocaine, but use beryllium. It's more effective. And only certify death if the temperature should be below 30 degrees, if the chest is frozen, or there is complete ice impaction of the upper airway. Your complications, well, we've talked about them. Hypothermia, you get the after drop in warming. Hypotension, drop in pH, the coagulopathies. Rhabdomyolysis is also a risk factor. If it's frostbite, remove all the constrictive clothing and jewelry, just like you do for a burn. Immerse the affected area in warm water and then refer to the surgeon. Remember, amputation can be delayed, and actually the surgeon will not operate immediately because he wants to see where the demarcation between dead tissue, necrotic tissue, and normal tissue. It's been suggested that ibuprofen and strong opioids may be needed, but don't forget tetanus toxoid booster and elevate the part to reduce the swelling. Current modern day evidence is the use of TPA that may improve perfusion and reduce the extent of the amputation. But please make sure you don't exclude a compartmental syndrome. This is something that it would be tragic. If the patient's cold and they're lying down for hours, the areas that are being compressed where they're lying down, the muscle will become ischemic, the muscle will break down, the pressures will go up in the compartment, and if that pressure is not detected early enough, the muscle will die, and you're leaving a patient with a huge musculoskeletal deficiency. Trench foot, just keep the feet warm, clean and dry, and elevate the extremities just to make sure that the patients are warm. And then finally, drowning. The young man who fell into the lake after a drinking session at Christmas time. What I was horrified to hear was that it's the third largest unintentional cause of death in low-income countries. So there's about 372,000 deaths a year, and most of them, we've changed the technical terms. We now call it a drowning incident. And a drowning is defined as a process in primary respiratory impairment from submersion or immersion in a liquid medium. The risk factors are the young, but especially those below the age of 5. But the good news is that they recover better because they are immature and the body's ability to repair is better than in a geriatric patient. Males more than females, tourists more than locals. We talked about drugs and alcohol. The elderly, it could be due to falls and comorbidities. So don't think of drowning as an isolated incident. Ask yourself, why did the person drown? What other factors, what other medical problems could have been happening? They occur in natural waterways, and obviously vehicles have gone into off the road and into lakes and rivers. Medical factors that contribute to this, maybe the arrhythmias, your myocardial infarctions, your diabetics who become hypoglycemic, the epileptic fit, etc. And the survival factors depend on the temperature of the water, how long you've been submersed, was it witnessed, and was the CPR, whether it's just compression alone or whether it's both ventilation and compression. The time of arrival of EMS and the initial rhythm. These are sort of important factors. And what kills you is that, first of all, you are panicking, so your respiratory impairment, you try to shout, you try to get to shore, and you have an increased metabolic demand, so you develop a metabolic acidosis, and you might swallow water. But once you've submerged, there's breath holding, and as you know, people's threshold for breath holding will vary from person to person. I don't think I could hold my breath for more than a minute if I'm lucky, and that's when the respiratory muscles become hypoxic, the airway opens, and they inhale a lot of fluid. And hypoxia is the main cause of death due to the release of laryngospasm and cardiac arrest and hypoxic brain injury being the lethal contributors. So if you see somebody in trouble, shout for help, try and rescue without getting involved yourself, call the EMS, start CPR and transfer. So always the safe approach, shout for help, approach with care, free from danger, start evaluation, and treat them. And if you look at the airway, remember these patients, if they've inhaled, will have laryngospasm or bronchospasm. Remember the reasons why people who drown die is because of hypoxia. Breath holding is variable. If it's salt water that's aspirated, it will pull fluid from the circulation. But if fresh water, it'll be flow the other way to increase the circulating blood volume. And we reckon if you've got more than 3 to 4 mils per kilogram aspiration, you're unlikely to have significant fluid shifts. But if you've got fluid going into the lungs, the surfactant, which is important for the integrity of the alveoli, is washed out. So you start getting atelectasis, and obviously you get alveolar damage, and that will increase the shunt process. In your circulation, just like in hypothermia, you get an initial increased sympathetic tone. So everything's hyperdynamic, and then the parasympathetic takes over. And you will develop supraventricular arrhythmias. But once you get PA or cyste, they're usually fatal, with only 5% having VF or VT. And we think that it's the immersion of cold water, the head into cold water, that causes them vaguely mediated cardiac arrest. And if you swallow seawater, you're going to vomit, and vomiting occurs in 30 to 35% of cardiac arrest. So vomiting is not specific to drowning. Your electrolytes, especially in salt water, may cause hyponatremia, but the thing that occurs in both heat extremes is acute kidney injury due to hypoxia and hypoperfusion. And what is forgotten, certainly at the early stages, but you would consider this in critical care, is infective complications. Pneumonia will account for, will complicate at least half of your drownings, and that's usually from the patient's oral pharynx, the microbiome of your oral pharynx. As the fluid enters the body, it'll take the microbes with it, and excuse me. And if they vomit or in contaminated water, there'll be further problems. And if the patient's immunocompromised, then you're likely to get fungal and other delayed brain infections. And the common infections in the oropharynx are the gram positives, and in freshwater it's gram negatives, and also fungal organisms. So certainly in burn critical care, for example, a microbiologist may take days to tell us what is going on, because quite often some of these fungal organisms are very rare and only peculiar to a certain area. So you have to know what is going on in your local area to work out whether you've got a fungal infection or some rare bacterial infection. So temperature control, if the water is less than 35 degrees, you're going to become hypothermic because of transfer of heat from the body to the surrounding water. And if it's 25 degrees, you get cold shock. And this is what prevents you from getting to safety, because the skin starts off the hyperdynamic situation, gasping, hyperventilation, increased cardiac output, and peripheral vasoconstriction. But ironically, deep tissue that's in the core, hypothermia is protective. And that's why the organs are not as affected as the skin and the subcutaneous tissues. But unlike the medically induced hypothermia, like after cardiac arrest, superficial cooling occurs first, not the core. And this will lead to weakness, slowed nerve conduction, and finally incapacitation. So you can see you've got the cardiac system, the respiratory system, and then the CNS and the musculoskeletal system all shutting down and basically going into a pre-morbid, pre-mortality state. If you're below 35 degrees, you'll have the shivering, but if that's not stopped, you'll eventually die. And below 28 degrees, you can be fooled, and it's difficult to diagnose death. So that is why that phrase, you're not dead until you're warm and dead. In contrast, if you drown in hot water, you get peripheral vasodilatation and a tachycardia. And in these patients, the risk is a drop in blood pressure and loss of consciousness as you vasodilate and the blood pressure drops. So basically, just don't stand them up, just treat them symptomatically. So in drowning, remove the patient from the water if it is safe for you. Start BLS. And you can do either breath or compression or both, because the rescue breaths can be omitted. CPR is only effective using flotation devices by those who've used it. Don't try and use it for the first time in anger. And what I was surprised at, the injury is a cervical injury to the C-spine is low, unless, of course, it's an obvious thing of somebody diving into a shallow water. So immobilization of cervical spine is not important. In ED, you will basically resuscitate them, do a drug screen in your other investigations, but also a CT scan, like Nelson mentioned. If you've got a CNS problem, you want to know there wasn't an intracranial event or a traumatic brain injury or cerebral edema occurring. Hemodynamic instability, we've covered fluids and vasopressors. Be careful of using vasopressors. Make sure you filled up first. Active rewarming till the core is 34 degrees, then do passive warming. And then when stable, look for non-accidental injuries, especially in the elderly and young children. This could be a deliberate attempt to kill them. And in scuba divers, think of decompressional illness. In intensive care, it's basically organ support, neuroprotection, and prevention of multi-organ failure. And we aim for therapeutic hypothermia at 36 degrees for evidence which is limited. There is no evidence for steroids, intracranial pressure monitoring, or barbiturates. So the jury is out on it. So don't complicate the case by giving steroids or trying to put an intracranial bolt or giving barbiturates. If you're drowning, what are the poor prognostic factors? Submersion beyond 10 minutes, resuscitation delayed for more than 10 minutes, GCS less than 5 unreactive pupils on arrival in hospital, not at the place of drowning, a pulseless or apneic on arrival in hospital, a pH less than 7.1 on ABGs, and if you need to go on extracorporeal life support mechanisms, or acute kidney injury. Those are the bad prognostic factors. So the majority of drowning will only aspirate small volumes and recover spontaneously. So if their GCS is above 14, examination is normal, chest X-ray is normal, ABG is normal, observe them for 6 hours, you can send them home. However, submersion time is the strongest predictor, and these patients really need to be on intensive care. And when you do a CT scan, the early loss of gray-white differentiation of the brain matter has the worst outcome. And up to 28% after a survival for drowning followed by CPR will have a neurological deficit for the rest of their lives. And for completion, the two trends of therapeutic hypothermia and targeted temperature management are relatively new interventions, and basically what they do is to try and reduce the temperature sensitive consequences of cellular injury. That's all. It's preventing further damage from temperature damage. And you cool the brain down, so the metabolic rate of the brain goes down, so the requirements become less, oxygen extraction becomes less. And fun enough, it increases immunity. So you remember, these patients are immunologically suppressed by the insult, and also reduction of intracranial pressure. So TH and TTM have lots of other potentially helpful, but not completely defined yet. So for the adult post-cardiac arrest, we reckon 32 to 36 degrees for these 24 hours. The case in children is still to be decided, and there is a very rare need in neonatal hypoxic ischemic encephalopathy. But there are problems if you have got therapeutic hypothermia. It's going to mess up your potassium and insulin control. How do you interpret your arterial blood gases and acid base, which is normally based at a temperature of 37 degrees? So so how do you interpret these figures? Alpha stat or pH stat, that's a huge controversy. So you need to define that for your own unit. There's a fear you might mask sepsis for the fever of sepsis because you artificially cool the body down. It's going to affect the dynamics and the kinetics of the drugs that are going to a patient. So, for example, drugs will act longer if the metabolism from the liver is reduced by the hypothermia. How do you use anticoagulants? Because you know that you get a coagulopathy when you're hypothermic. So there's going to be a decision as to whether you used your anticoagulants or your thrombolysis in these cases. It is known to be safe with percutaneous coronary interventions, and if a patient's pregnant, then there is worry about the fetus on board, but that is so rare that the evidence has still not been established. And also, if the patient's had a traumatic anoxic brain injury, what is going to be the neurological prognostication? In other words, how do you assess the brain function whilst they're on critical care? So today I've tried to cover very rapidly the issues of hypothermia, and drowning, and I'll be happy to take any questions. There are two papers that two references I'd recommend. This one, which has just been published in Nature Reviews, is absolutely fantastic. Professor Buchama is professor of anesthesia at Riyadh University in Saudi Arabia, and he is one of the world's leading experts on heat disorders. And the other book is a paperback, but it's very hard reading. It's by Ken Parsons, who's professor of engineering at Loughborough University in England, and he's the leading expert on heat, especially cold stress, and that will give you all your figures about if you want any information on clothing in cold weather. That's the book to read. Any questions?
Yes, thank you, Winston, for a very good lecture. I was going on and off, but I managed to follow at the end. I don't know if you covered this, but I was wondering, what are your thoughts regarding sauna or cryotherapy, and if you've had any incidences where someone went, for some health reason or some fitness reason to these facilities and then ended up in the hospital. Thank you.
Yeah. Okay. I mean, sauna is usually a recreational thing, so you can have problems in a sauna from heat stroke, and especially if you're not healthy. If you've got cardiac disease, respiratory disease, it can have a problem. Cryotherapy, to my knowledge, I would say would be experimental, but for most of the thermal disorders, I would say the importance of getting the normal temperature range with the strategies I talked about are probably the only thing that has got an evidence base for it.
But are there any benefits of like this heat therapy?
Not to my knowledge. Not for things like sauna or cryo. They would be very specialized. The only time cryo has been used is in cancer surgery, where cryo has been used to kill cancer cells in focused areas like in prostate cancers or metastases in the liver, but not for heat disorders as such.
So the last time I had a good read about heat stroke, the consensus was that dantrolene had no role in heat stroke, but was still good for malignant hypyrexia. Is that
Correct.
still the case?
Yes,
yeah,
it is. Thank you, Tom. I knew there was something I'd forgotten. Dantrolene is the a specific drug of choice for malignant hyperpyrexia. So we have this in every operating theater, not every, because it's very expensive. Dantrolene is specific for malignant hyperpyrexia. It is very difficult to dissolve, so you usually need one person just to dissolve the drug in the first place. But just remember, whilst you're trying to give dantrolene, you must also simultaneously cool the patient. Cooling the patient is what's going to save the brain. There was evidence, as you said, of using dantrolene in heat stroke, and the trials were all negative, and in fact increased the morbidity, and therefore we now say that dantrolene should not be used for heat stroke, and it's only specific for MH.
Fantastic. Thank you. Very reassuring.
Anyone else? You've probably got heat exhaustion or cold exhaustion, depending on where in the world you are. Ibrik, I think that's it. Thank you, everybody. I hope you had at least an overview of the extremes of temperature regulation. In the PDF, for example, I've put some extra slides for those that are going on expeditions. Put some information on acclimatization and acclimation, so that you can give advice to your team. The bottom line is, if you are going to a new environment, it takes a week for the basic systems to work, but to be properly fit, 2 weeks. Okay, so if you're planning an expedition, you're going to a hot area, for God's sake, think of all the factors and make sure a normal person takes about 2 weeks to settle in. If you're a fit soldier, a fit athlete, you probably could get away with a week. Somebody like me, probably 6 months.
It's okay.